Hi, in this lecture, we're going to go ahead and wrap up our articulations material by looking at some special joints in the human body and some clinical applications. So you've probably heard of your temporomandibular joint. This is called TMJ, and this is the joint that's between your mandible, which is your lower jaw, and it actually articulates on the temporal bone of your skull. And this is the joint that opens and closes as a hinge joint, but it also can glide because you can protract and retract your jaw. You can move your mandible forward and backward. So this is a special joint. It's considered a modified hinge joint because, again, it can move forward slightly. And this is the one that often can be irritated if you grind your teeth or clench your teeth. You might notice like a clicking or a locking pain when they talk about TMJ syndrome. So sometimes you might have a mouth guard to try to relax those muscles and try to help this joint work better. Now, the pectoral girdle, we've looked at the bones, and we're just going to talk briefly about the joints there. And this came up in your lab, but when we look at the pectoral girdle or shoulder girdle, there's three joints that we look at here. So you have your sternoclavicular joint, and your sternoclavicular joint is literally the connection between your sternum, put an S there, and your clavicle, and it's a very, very strong joint. Now, if it were to dislocate, you would not miss that. You can actually see it protruding there, but it's very strong, and typically it does not dislocate. So it is an example of a synovial joint, but more of a gliding joint. There's not much movement there. If we look at the AC joint, remember the AC joint is between the acromion, remember that's the top part that you feel on the scapula, you might think of it as the top of your shoulder, and where it articulates with the clavicle. So when you palpate the top of your shoulder, the clavicle actually comes right over here and attaches to it. Now your AC joint is another example of a plane or a gliding joint, and if you have a separated shoulder, usually it's some form of trauma that pushes the shoulder up and it separates the AC joint, and you can see damage from that. Now, what we primarily look at is the shoulder joint. So the shoulder joint, it's fine to call it the shoulder joint or glenohumeral. This is your ball and socket joint. This is your triaxial joint. It's one of the most commonly dislocated joints in the body. And often what happens is the head of the humerus actually pops forward when it gets dislocated. So you usually have an anterior dislocation where it moves forward, and also it tends to drop down. You can't miss it if you see one. And then they need to reduce it, and reduce it means they need to put it back in place. And so once you dislocate it, you stretch and even tear all these ligaments around the joint capsule, and a lot of times you're going to need surgery to correct it. Now, when we're looking at ligaments, by the way, let me jump back here. You have some ligaments in your notes. Don't worry, I'm not asking you these specific ligaments. They are just there to stabilize the shoulder joint, and the reason that they're listed, you see acromioclavicular, so it's just a ligament that helps anchor the acromion to the clavicle. Coracoclavicular, coracoacromial. We're not going to worry about labeling those. In the past we did. You can see where they are. I just want you to recognize that ligaments are named according to the two bones they join. So you can always figure out where a ligament is if you look at its name. And when a shoulder is dislocated, these ligaments are typically definitely stretched, if not torn. Now you have something called the labrum, and the labrum is fibrocartilage, and it kind of lines and makes a little cup on the inside of that glenoid fossa, so it's called the glenoid labrum. So it forms like a cup, and it helps hold the head of the humerus in place. So it's really important for stabilizing the shoulder joint. Notice that the biceps tendon comes right up, and it actually inserts on part of that labrum. So if you have damage to a shoulder dislocation or a labrum tear, often you can damage the biceps tendon as well. And so often this labrum can be torn in dislocations and twisting forces, and then that requires surgery. Now, the other factor that helps maintain your shoulder girdle or pectoral girdle are your sits muscles. And the sits muscles are the rotator cuff. So these muscles obviously help with rotation, but you can see where they're located, and they actually help stabilize the shoulder joint. So often you can have rotator cuff injuries. So remember, you have the supraspinatus up here above the spine, the infraspinatus below the spine, and then you have the teres minor right below the infraspinatus, and then the last S was subscapularis. Remember, that's on the anterior side. We also mentioned briefly the SI joint or sacroiliac joint. This is another gliding joint or plane joint, synovial joint, and you can see that it's articulation between the ilium, and so you might recognize what you're seeing here is that posterior superior iliac spine where it meets with the sacrum. Now you'll see the sciatic nerve, and remember that's going to pass down, let me erase this a little bit so you can see, the sciatic nerve actually passes through the greater sciatic notch, and so sometimes if you have SI joint issues or sciatica, it can compress or push on that sciatic nerve, and the term for sciatica literally means, that's an I, that you're causing inflammation or pressure, and it can radiate all the way through your gluteal area. It actually runs down the back of your leg and off to the side of your leg. Okay, intervertebral articulations. So we're looking at the vertebra, and we know the vertebra have the disc between them. So now we're looking at fibrocartilage. So these are examples, remember, of symphysis. Anytime we have a fibrocartilage pad. And so it's the body's natural shock absorption, right? They sit between the vertebra. Now a disc, this intervertebral disc, has two parts to it. It has this outer area, which is pretty tough and strong, and inside is the original gel material. So the annulus fibrosus is the outer portion, and inside is this gel-like material that's really good for shock absorption. So I kind of think of it almost like a jelly donut, where the jelly inside is this nucleus pulposus. So what can happen sometimes is you can have what's called a slipped disc. A slipped disc is when that annulus fibrosus starts to bulge. So remember, you have that outer piece there, and then inside we have our gel, right? Our jelly and our donut. So if there's some sort of force that's applied, it can push on this, and it can kind of like squeeze the jelly. So if you were to compress it, think about a jelly donut. If I push here, then the jelly is going to get squirted, and you'll see a bulge. And the issue is that these little holes here, these are where spinal nerves come through. So this can push on a spinal nerve and even your spinal cord and cause a lot of pain. Now, a herniated disc is when it completely breaks through. So herniated needs to typically be surgically repaired. And again, the herniation or the bigger slippage, let me go here, you can see again that you push it, it gets compressed to one side, and it can actually herniate, and it actually protrudes through and puts more pressure on the area. Okay, now the knee joint we looked at in lab, so we're just going to talk quickly about it. It transfers weight from the femur to the tibia, and remember there's the menisci, so these are fibrocartilage pads. So here's another symphysis, right? One of our other examples was the knee joint. Remember that the medial meniscus is more C-shaped, and the lateral is almost perfectly circular shaped. So these are really important for giving support to the knee joint. They cushion, they stabilize, but they're anchored on the outside. So since the medial is C-shaped, it's only anchored on the outside, more of it is exposed. So you're more likely to damage the medial meniscus in an injury. And so usually what happens is if you stop and twist, that's going to tear that meniscus. And by the way, we're looking at cartilage, so it only gets blood around the outside, and as the further you go away from that edge, the less blood supply it gets. So when we look at the knee joint, we looked at the ligaments in lab. We have our LCL, which is joining basically our femur to our fibula, and then we have the medial collateral ligament, which runs from femur to tibia. And then remember, we have the cruciate ligaments, which crisscross inside. So we have the ACL. Remember, they're named from where they start. They originate on the tibia. So the ACL originates on the anterior tibia and inserts on the back of the femur, whereas the PCL originates on the back of the tibia and crosses to the front of the femur. So these are the ligaments that are really important in preventing your tibia from sliding forward or backwards. So here's another image of the knee joint, you can see the PCL a little bigger. So the PCL prevents your tibia from moving backwards, and your ACL, which you can see here in the front, prevents your tibia from moving forward. That's why a blow to the back of the knee can push the tibia forward and tear an ACL. So let's look at some of these knee injuries. So we have MCL, ACL, and meniscus. These are the most commonly damaged areas of the knee joint. So if we look at our MCL, remember it's on the medial side. So if there's some sort of blow, oops, I just realized I hit the wrong button there. If there's a blow from the lateral side, you can see how that will stretch or strain, and technically it's called a sprain, the MCL. Whereas if you had a movement come from inside, that would tear the LCL. Well, you're more likely to have a blow from the lateral side than something coming up between your legs. So the MCL, unfortunately, can be commonly torn. When we look at the cruciates, we're really looking at the tibia moving. So if something should push the tibia forward, then what's going to happen is you often can tear your ACL. And if something pushes it backward, you're more likely to tear your PCL. And again, you're more likely to get hit by something from behind than coming in front of you. And then this is showing you another view. If you have a blow from the lateral, especially if your foot is planted. So if you plant your foot and twist, then you can often get your MCL and your medial meniscus. And so there's something called a terrible triad that happens when, unfortunately, if you're running and you suddenly change direction, you plant your foot and twist, then what's going to happen is you can do your MCL, your medial meniscus, and even your ACL. Now, when we're looking at the meniscus, you can see it's torn here. It's not attached to the tibia. And so what we worry about, with that is that it's not real vascular. So sometimes you have to go in and you have to sew it back together. So interestingly enough, my son had a torn meniscus and was given the green light to continue in his sporting activities until it was time for surgery. And when his surgeon went in, the whole piece was actually torn completely out. It was severed, so he ended up just removing it. And I meant to put a picture of that in this PowerPoint, and I forgot to do that. Okay. I actually went and got the picture and threw it in this lecture. So it's kind of cool to see because you don't really know what it looks like. So here's the, when they went in, these are pictures the surgeon took during the surgery. This was a piece of cartilage that had broken off. This is what it's supposed to look like. Well, there's supposed to be cartilage right here. So basically he had to cut that piece of cartilage out because it was loose. And then he put it on a ruler and he showed it to me. And you can see he's missing a pretty good chunk of cartilage. Now, that's about 2/3 of the medial meniscus, if you're curious how big it is and what it looks like. So he's fine, but when he gets older, he's probably going to have some issues with that knee. Now let's finish up the clinical. So again, we looked at some of the knee injuries, the sprain and a strain. So a sprain always refers to an overstretched ligament, and they vary. They're usually graded as 1, 2, or 3. So 1 is a typical sprain. Now it hurts, right? There's nerves in here, so it's pretty painful. Usually you have to do your RICE, right? Rest, ice, compression, elevation to reduce swelling. Grade 2 is a partial tear. Sometimes they need surgery, sometimes they don't. A grade 3 is completely torn, and you have to repair it surgically. Remember that we're looking at ligaments, and ligaments are dense, regular connective tissue. They are not elastic. They don't return to their original size if you stretch them. A strain refers to a muscle. So when we stretch a muscle, that's called a strain. Okay, so we have dislocations and subluxations. So a subluxation is when it's a partial dislocation. So what it means is usually the head of the humerus or the hip, used to happen with your thumb, it slides out, but it doesn't slide all the way out of the whole joint. So sometimes they just slide back in on their own. Sometimes they're put back in. It definitely damages and makes the joint looser, but it's not as severe as an actual dislocation. So you can see a shoulder and a hip dislocation. And again, a lot of times that head of that humerus pops out anteriorly and inferiorly. And now you've damaged the cartilage, the ligaments, the joint capsule. You could also damage the labrum. And so now you need surgery, and they go in and they can sew all of this back together and tighten the joint back up again. If you don't treat it surgically, you're at a greater risk of having a dislocation occur. in the future, because let me go back really quick, because a lot of times, remember, this tissue is not elastic. It doesn't return back to its original size after you stretch it. So it's always going to be looser and more prone to injury. Bursitis and tendinitis, when we see itis on the end of the word, we know that that's going to be inflammation. So bursitis, these are both painful. They're usually due to overuse and friction. So a lot of times the bursa, just either between the muscle and the bone or the bone and the skin, just constant friction can happen. It could happen from infection. So you could have some sort of like cut and have an opening and some kind of bacteria get inside the bursa. So remember that they can test this by draining some of that synovial fluid out of the bursa. And if it's like a cloudy yellow, that's a classic sign of infection that could be happening in there. And then tendinitis, remember the tendon sheaths are going to go over those long tendons that cross through your forearm and your wrist. This is usually an overuse injury. And again, most of the treatment for bursitis and tendinitis, I come back to this, but it really works, is to rest, ice, compression, and elevation, and then it'll usually heal if you can give it some time. Now, arthritis is going to cause rheumatism, and rheumatism is just a generic term for pain. Your pain, and you might feel stiff in your skeleton and your muscle. There's different types of arthritis. So arthritis is inflammation of a joint, because remember, arthro means joint. So when we look at arthritis, we'll talk about several different types. One of the more common ones is going to be osteoarthritis. So you have a little table there in your notes to fill out, and we'll jump right back to the treatment. But I just want to mention really quick, osteoarthritis is probably the most common arthritis. Usually people over the age of 60, but I'm not 60, and I have arthritis in my thumbs from years of writing on boards and typing. So it can happen at any age. It does tend to be genetic, so it could be caused by genes. You might have the genes to have this type of arthritis. It's usually wear and tear, just overuse of injuries, and it affects the collagen production. Now, let me jump back for a minute to treatment of arthritis. So any arthritis or rheumatism, things we do is, like we already said, rest and immobilize, right? So rest it. Usually these things settle down. If you can rest and immobilize it, you might need a splint, or you might need to tape it so you can limit the range of motion and let it heal. We know ice works. We know that ice vasoconstricts. It decreases blood flow to the injury initially, which is going to decrease the swelling, and it will help reduce the swelling, which helps reduce the pain. There's different pain creams that you can take as well, and you can rub on the joints. So they do know that some of these creams can stimulate receptors. Basically, they can stimulate alternate receptors in the skin for that, like, for lack of a better word, like that sizzle, or some of them are kind of like tingly because that activates those nerves so that you don't feel the nerve or the pain. So a lot of them come from capsaicin, which is basically like a hot, I know it's a chili pepper, but it comes from a really hot pepper. So it can cause like a burning sensation or make it really, really warm. And so what that does is it helps reduce the transmission of pain. Some of them actually decrease something that's called substance P. And that's a P. Substance P, someone was nice when they named it. Substance P causes pain. So capsaicin is supposed to help block substance P and reduce pain. And then you can also do the NSAIDs. I skipped those. The NSAIDs like ibuprofen, naproxen, aspirin. So what they do is they interfere with key enzymes that help form pain or cause the pain pathway, so they block them. So you don't make the prostaglandin, and then therefore you don't have the pain and the inflammation. So they can directly suppress inflammation. So it's non-steroid, anti-inflammatory, basically drug. So that's your NSAIDs. They directly suppress. Cortisone works great. It's going to suppress inflammation. It kind of lets the immune system back off a little bit, but you really don't want to be on this for a long period of time. People might get cortisone shots or injections to help decrease inflammation because, again, remember, if you decrease inflammation, you decrease pain. But cortisone levels can ultimately suppress the function of your immune system, and it can make your bones become weaker. There's diet. There are some foods that we know tend to cause more inflammation. And so sometimes changing your diet might help as well. And then if it's bad enough, you might need a new joint. So you might have to have a surgical replacement of that joint. So we started to talk about osteoarthritis already. So again, it's most common with aging. And so it can be due to genetics and due to overuse. But what specifically causes it is the articular cartilage starts to wear away. So there's a decrease in collagen. And the articular cartilage, you can see it starts to wear away and the bone becomes more exposed. And over time, those bones can rub on each other and you can get what's called a bone spur, which is like a thickened piece of bone that kind of protrudes. Now, osteoarthritis, you can see, typically can affect any joint in the body. A lot of times you'll see it mine's in my thumb. You get it in your hips, your knees, right? Knees are pretty common, low back. So signs and symptoms are going to be pain and stiffness. A lot of times they'll swell, painful to touch. Sometimes they might grind, or like you might notice when you move the joint, you feel like this grating sensation. And again, the primary treatment under additional treatment is going to be your classic treatments here. Your rice, your NSAIDs, creams, cortisone. And if it's bad enough, then you have to replace the joint. Pretty sure every joint in the body can pretty much be replaced. They probably do a lot more, my guess would be knee replacements and hips. Now, RA, or rheumatoid arthritis, is different. So this is much more common in women than men, 3 times more common, and it's an autoimmune disease. So autoimmune means that the immune system attacks the joints. In this case, attacks the joints of the body. And autoimmune diseases tend to affect women more than men. So, what happens is the immune system attacks the joints, and when it attacks the joints, it forms scar tissue, and then it ossifies it. So it's called ankylosis, and what that means, it's a fancy word, it just means that the joints start to fuse together. So you have an increase in swelling of the joint, there's more fluid. Eventually, as the immune system attacks it, you get scar tissue and the bones ossify. So it usually affects the smaller joints of the body. It might start in like the wrists, the elbows, the hands, the ankles initially. And as far as treatment, you can try the treatments we already talked about, your typical treatments. But there's also people with RA are probably going to go on drugs to suppress the immune system. So they're more likely to be on prednisone, cortisone, and there's some newer drugs out that basically try to decrease the immune system so that it doesn't target that joint because it's your own immune system. So you can see there's some common things between osteo and rheumatoid, but there's a lot of differences. And this is a picture showing you the joints that can happen when they get fused. Okay, you can see the x-ray and then you can see the patient. And so again, we would use our NSAIDs and corticosteroids to suppress inflammation, but there's some new ones. So methotrexate, I believe that was actually first used as a chemotherapy for cancer, but it seems to help with RA, and it's always kind of scary when you're like, we don't know why it works, but it works. So it seems to be helpful. And then you have gout or gouty arthritis. So this is going to be most common in males, and it is genetic. So if you're male and your father has gout, there's a higher chance that you will. And it happens when crystals build up in the body. Excuse me. So they're usually uric acid or calcium salts, and they start to accumulate in the synovial fluid, and they go to the lowest point on your body. So a gout attack typically starts in your big toe. So it's the main joint, just because gravity carries them all down there. So you might have redness, a lot of pain in the joint, and a lot of times it's a metabolic issue. It's with processing certain foods. And if you have gout, you probably want to avoid a lot of fatty meats and alcohol. It used to be called the rich man's disease because if you were rich, you could afford those foods, but that has a lot of uric acid in it, and it could cause a gout attack. And then I threw Lyme disease in here because it can cause arthritis. It doesn't always, but it's caused by a bacteria. It's a spirochete, and you probably know that the tick feeds on the deer, and then it feeds on you, and it gets infected with the bacteria. And then when it feeds on you, it sounds gross, but before it removes itself from your body, it regurgitates into you, and that's where it transmits the bacteria. So you can see a dime and how small the larvae are. And so this causes, usually you get inflammation. That's where they talk about the bullseye rash. But later, it can actually cause a type of arthritis, which can be very painful. And then I just wanted to mention really quick that, we need to immobilize joints sometimes if we're having a lot of pain, but you don't want to reduce it too much. So if there's no immobilization, you can decrease synovial fluid, and it actually makes your joints hurt more. We know that, I didn't put this in the treatment slide, and I should have. We know that exercise helps with arthritis. But sometimes you can do water exercises if you don't want to have the weight-bearing exercises. But when you exercise, you increase blood flow to your joint, and it does help with a lot of arthritis symptoms. And then you can do passive motion. Sometimes you'll do physical therapy as well. And then I mentioned this before, but we just know as we do get older, we do increase our risk of fractures and dislocations and joint injuries with age. So this concludes our material for the articulations chapter.